The goal of the Expo is really to facilitate knowledge sharing in the area of activity-based therapy. My name is Kristen Walden. I'm a physical therapist working in the area of spinal cord injury, both clinically and for the Praxis Spinal Cord Institute. And I have the pleasure of walking you through our agenda for today. So next slide. So we're going to start off the day talking a bit about an activity-based therapy summit that was held last year. And you'll get a review of some of the priorities that came out of that summit. Following that, you'll hear about an activity-based therapy technologies and perspectives inventory, looking at some of the results and the outputs from that project. You'll get an update from the Mars Innovation Spinal Cord Rehab Innovation Challenge, which is a challenge, a competition currently open in the area of activity-based therapy. And then we'll go through two sets of roundtable presentations where you'll hear from a series of speakers, and that will be followed by a question and answer and networking breakout session. After that, we will close the meeting. And just a reminder for those of you who are members of the Community of Practice, there will be a Community of Practice meeting following the Expo.
Welcome to the Expo. My name is Kristen. I'm at the University of Toronto in the Department of Physical Therapy and also at the Toronto Rehab Institute. And so what I'm going to do right now is just walk you through sort of what led up to where we are today. I'm going to start by just briefly mentioning a little bit about the ABT Summit to give you some background on what this initiative is. I'm also going to define ABT, so activity-based therapy. So these are therapeutic activities that involve repetitive neuromuscular activation below the level of spinal injury, typically achieved through intensive task-specific movement practice. And so this is a definition that our group has modified off one of the original definitions from Behrman and Harkema. So in March 2019, in Canada, the Praxis Spinal Cord Institute hosted the ABT Summit. And this was a day-and-a-half meeting where about 40 of us came together to discuss ABT in Canada. And we were tasked with one large goal, which was to come up with priorities to move the field of ABT forward in Canada, so to improve the access to and also the quality of ABT. So we met in Toronto over that day and a half. It was a diverse group, so there was frontline clinicians, administrators from both hospital environments and community-based clinics, people with lived experience, researchers, funders, innovators. And through a process of small group discussions, consensus building exercises, and then also a post-summit online survey, we did come up with 5 priorities to move the field of ABT forward in Canada. So I'm going to briefly just go over what those 5 priorities are. So one was to identify current ABT activities across the continuum of care in Canada. So really to get a snapshot of the current state. And so we wanted to understand more about what technologies were available and being used, as well as the different interventions and how the ABT programs were being delivered. We also want to create a network to facilitate dialogue, across hospital and community sites. Another priority was to track engagement in ABT activities. So the thought here was to develop a standardized tool or multiple tools that could be used to document what is happening with ABT, what are the outcomes, and this could be used across sites to start producing some robust data. We also wanted to develop and implement best practice recommendations for ABT. So this included things such as coming up with some common terminology, develop metrics for ABT delivery, but also then support implementation when these best practice recommendations would be developed. And then lastly was to study optimal timing, methods, and dose of ABT. So first to summarize what research evidence already exists, because there is quite a bit of evidence out there. And then to look at what research needs to be pursued, but also to consider how to take an individualized approach to ABT. And lastly, also to build the neurophysiological evidence behind ABT. So those were our 5 priorities. And then what's happened over the past year and a half is we've started to work primarily on the first priority, but I forgot to mention first. So with those 5 priorities, there were some what we call cross-cutting categories, which are concepts that we feel are important for all 5 priorities that need to be considered as we move forward in our activities. So the importance of behavior change strategies, especially at the time of implementation, the need for economic analyses to support ABT interventions, linked data, remember to include upper limb, because of course much of the literature is focused on the lower limb to date. Create innovation collaborations, incorporate reliable technology for a variety of purposes related to ABT. Produce rigorous and valid research. And also part of our approach has been really to build upon the strengths that have already been developed in the stroke rehab research and care activities in Canada. So since that first meeting in March, there's been a number of different working groups that have been developed to start moving some of these initiatives forward. And so far, they've primarily focused on the first 2 priorities that I mentioned. And I just wanted to acknowledge the people that have been helping out with these different initiatives. We've been divided into 4 different working groups, which we will tell you a bit more about in a minute. But some focus on trying to look at what's happening currently in Canadian hospitals with respect to ABT, community clinics, and also building an inventory of what ABT resources such as technologies exist in Canada so that can be shared with clinics and with hospitals, and then a dissemination group as well. And so what will happen next is we've asked some members of these working groups to give brief updates of what their groups accomplished over the past year. So Dr. Sarah Donkers from the University of Saskatchewan will give us an update on what the inventory group is about and what they've been doing. Hope Jervis-Rademeyer, who's a PhD candidate at the University of Toronto, will talk about the work that the hospital working group has completed. And then Dr. Cindy Gauthier, who's a postdoctoral fellow at the University of Toronto, will give us an update on the work that's been done looking at ABT in the community. And I'll briefly mention in terms of the dissemination group, so some of these activities you'll sort of see interwoven throughout some of the presentations today. But since March 2019, we've offered 2 webinars, 2 free webinars on ABT related topics. This group has also spearheaded the development of the community of practice terms of reference, which are in draft, created the ABT Expo that you're at today. And there'll be also some info provided on a podcast that Hope has been working on over the past few months. And there's also a video series being planned and produced as well. So with that, Sarah, if you're on the line, I'm going to pass it over to you.
You bet I am. Thank you. Hi, Kristen. Good morning, everyone. Thanks for joining us. A special thank you to our West Coasters who had to get up slightly earlier than I did. Okay, so I'm going to talk a little bit about the inventory. So I want to say thank you to everyone who was involved in either the creation of the inventory, participating in completing the inventory, filling it out, or in our analysis and interpretation of the findings so far. As Kristen just mentioned, it was one of our top 5 priorities from that summit, and we wanted to identify what are the current ABT approaches and equipment being used across Canada. So it really was this snapshot in time, and it was focused on equipment. So we collected information on types of equipment and technologies being used across different ABT goals. So both in that functional neurorecovery component, as well as that prevention of secondary complications. We looked at the setting for use and the type of client that this equipment and these goals were being used for. And based on the discussions within our inventory working group, we decided to take a who, what, why, and how approach to analyzing the completed inventories. So who was really looking at the setting, the type of therapists, and what clientele. The what was the type of equipment, so treadmills, locomats, weights, etc., but also classifying it into a type of technology, so a low, medium, high tech. Why was looking at what goals, what equipments were used in what settings, and how was if we could glean any information on frequency or protocols that were guiding the application. So we had 22 sites from 8 different provinces across Canada complete this inventory. Thank you again. And some preliminary results was we learned in the inpatient setting that ABT was primarily delivered by physiotherapists, and in our outpatient, both PTs and OTs were delivering ABT. And that compares to our private setting. So with our more chronic care community settings, ABT was delivered primarily by exercise therapist or kinesiologist, but followed closely by physiotherapists. So the demographics of our ABT clientele differed greatly across sites as well as across functional tasks. But based on the sites sampled, it appeared that overall ABT is primarily being used with individuals who had incomplete paraplegia or the Asia C&D. It appears as though our primary use of ABT equipment is still being focused on that secondary complications or emphasizing general fitness. And there were some sites that focused on using the equipment to really support that neurorecovery component and work on the functional tasks. But I have to say that we also learned that the application of the equipment and the ABT goals varied within a site, so between therapists. So protocols were rarely used and there was lack of consistent ABT definition. So yeah, that application was seen both within a site and across the sites we sampled. We learned that mostly lower tech equipment is being applied across the goals and FES aerobic equipment. So the FES bike was definitely the most common high tech equipment we saw. Some of the other higher tech equipment we saw were limited to a few sites and appeared to be acquired through research and not necessarily integrated into the routine clinical practice after that study was done. So we are just finalizing the grouping of our equipment, and I have to say there was a lot. So we're working on being able to do a final count, which would allow us for some higher level interpretation. So we want to be able to map out or show any relationship or pattern between the different types of equipment, the setting they're being used in, and the spinal cord injury type or severity they're being used with. So yeah, we look forward to sharing these results and the inventory manuscript in the near future.
Great, Sarah, thank you so much. Excellent overview. So I'm going to ask Hope if you wouldn't mind sharing your information. Thank you.
Sure. Hello, everyone. Many of you know me, but I'm Hope Jervis-Rademeyer. I'm a physiotherapist and PhD candidate at the University of Toronto. And our study from the hospital working group is looking at therapist perspectives on using technology to support ABT in hospital settings after spinal cord injury or disease. The main objective of this study was to determine if and how ABT and or technology are used in hospital settings for SCI rehab practice. So, okay. So for this qualitative descriptive study, focus groups were conducted at nine rehab sites all over Canada, actually. And there were 22 participants consisting of 12 PTs and 10 OTs. So thank you, participants in that in those focus groups. Semi-structured interviews were conducted mostly over the phone with one in person, and they were in both English and in French. And we used interpretive description as a methodology to inform clinical practice. So this slide shows the themes and categories that came out of this research. So the first is factors that influence therapist decision-making approach to ABT. So this includes clinician roles. So those might be official roles such as manager of a hospital department, or they might be unofficial roles. So maybe a learner or a mentor of ABT or technology. Site-specific dynamics, so what's unique to each site, and goal setting. The second theme we identified was clinician perceived patient individual factors. So clinicians perceived confidence, motivation, tolerance, mourning period, and self-advocacy in different patients that they worked with. And then the third is access to ABT and equipment. So how is that technology being used? Logistical and invisible barriers and facilitators. So just to explain an invisible barrier facilitator, that might be something like an occupational therapy and physical therapy department competing for the same grant. So you wouldn't really notice that right away unless you got a little bit more in depth. So our conclusion so far is that the understanding of ABT and/or facilitation of ABT using technology in rehab and hospital settings, it really varies across the country. So in these settings, we need to improve education just so it's not so varied across the country, so that we can ensure implementation as it works for each site individually. Yeah, so now you can go to the next slide. Thank you. So I sort of snuck in my podcast information here too. So obviously with my study and the other studies, we have identified a real need to promote ABT and to educate people on ABT across the country. A good start is targeting clinicians. So this is my podcast that I created along with support from Praxis. So it's called Spinal Moves, and it's targeted towards clinicians across Canada, but it's going to be, it's going to be accessible for the regular everyday person, for someone with lived experience, someone who's just interested in learning more about therapies and spinal cord injury rehab in Canada. So these are the working titles and descriptions of 9 different episodes. And it's going to take place, they're going to be about half-hour shows. It's going to start in January, and it's going to be released weekly. And the first show will be an introduction to ABT. The second show, I'll be interviewing people living with spinal cord injury who've used ABT. The third show, therapists who work in neurological settings. So this will be across the continuum, so acute, hospital, and community care. Current research. So actually Anita is going to be a guest host. Thank you, Anita, on some of these shows. So she'll be interviewing myself, Cindy, and Lovisa, who've performed some of this research, as I talked about recently. And then the next 2 shows will be on ABT and technology. So just an introduction to how technology can help support ABT, some popular methods of technology, for example, FES Cycling. And then the next show will be about epidural and transcutaneous stimulation and how we can use ABT to help with these interventions. The 7th show will be how to set up a clinic in your community. And the 8th show will be ABT and the experience abroad. So people who maybe have had epidural stimulation implanted abroad, something like that. They've experienced ABT abroad, or they've come back here to experience ABT with the intervention they've had abroad. And then the 9th episode, Anita and I will just be summarizing the episodes and talking about interesting points. Thank you.
Thanks. So before you turn off your mic, there was one question from Dr. Chester Ho about the hospital-based study. Can you just explain the sites? So were acute care sites included, or what was the inclusion criteria around the physios and OTs that you interviewed?
Oh, thank you. They all had to work at rehab hospitals in inpatient or outpatient settings. So we haven't included acute care sites. That will hopefully be in an upcoming study. Actually, it will. Thanks, Dr.
Great. Thank you. Cindy, if you are on the line, are you okay to present your work?
Yes,
Thanks.
of course. Yeah. So hi, everyone. So for people who don't know me, I'm Cindy Gauthier. So I'm a physical therapist trained in Montreal. So I'm from Quebec. You can see with my accent too. And I'm currently doing a postdoc fellowship with Christian Musulman at the University of Toronto and UHN. So I participate in that project. I was doing the part in the community. So first I want to thank you everyone who participated in this project as a member of the team or as a participant. So it was really interesting to talk about what is actually done in the community and in all different clinics. It was all very, very interesting and very nice interviews. So yeah, I will present the result of those interviews and the perspective of clinician working in private practice rehabilitation site on activity-based therapy for people living with a spinal cord injury. So it's similar to what Hope just presented, but it was in the community. So the objective of that study was to understand how ABT was provided to Canadians with a spinal cord injury in the community. Specifically, we wanted to explore how is ABT provided, is technology used to provide ABT, and if it's used, how and why it is used. And we also talk about the perceived barriers and facilitators to offering ABT and using its associated technologies in the community. So you can change the slides, thank you. So during this exploratory qualitative study, we conducted semi-structured interviews with clinicians providing ABT in the community. We asked them open-ended questions about their experiences and perceptions about ABT intervention. And we use this interpretive description analysis to analyze the interviews. So in total, we had 4 physical therapists, 1 occupational therapist, 7 kinesiologists and 1 clinic owner coming from 4 different provinces across Canada who participate in the interview. And on your right, you can see the figure of the teams and their interaction all together.
To introduce our next speaker, who is Louise Pichette.
Great. Hi, everyone. Thanks so much. Definitely check out the website. There's a lot more information than what I'm able to go through at this time. Next slide, please. So obviously, with COVID-19 coming into play right when we were nearing the initial challenge deadline, there have been some updates. So if you had been engaged with this challenge a little bit earlier on, the initial deadline was in June, and we have really strict requirements around engagement with people with lived experience, in-person data collection to validate and to show the evaluation team that the solution was effective. And so we did update a few of those requirements in light of COVID-19 and considering the fact that in-person data collection has become very challenging. And so on the next slide, you'll see a summary of those updates. So notably, we extended the challenge deadline and we've opened up the requirements so that folks can submit plans for how they will engage people with SCI and how they will collect data in person, as well as how they've engaged virtually. So John has joined me for a couple of these informational webinars to talk about how virtual engagement can be done in a meaningful way. And we're working to connect some of our competitors with people with SCI virtually, just to make sure that that perspective is considered, especially for people who don't come from a background in spinal cord injury. If they come from a different space, we want to make sure that that perspective is considered in these submissions. And so if you have questions about any of these requirements, the most of the requirements beyond those have stayed the same, but happy to discuss that. Laurent, I think, has a question in the chat. How will IP be shared? So typically how we handle IP in these challenges is the IP rests with the person who submitted. So the IP is not taken by Mars. It's just the money is awarded based on the submission that's been proposed. And it's no strings attached. It's money that you get for having completed the challenge in the best way based on the evaluation criteria. Okay, perfect. Hopefully that helped, Laurent. If you can go to the next slide. So if you're interested in this challenge, I will encourage you, I've said this a couple of times, to check out the website, but we do also have our final information session coming up in just about a month. So I'll make sure to share the link to that Eventbrite page so that you can register if you'd like to learn more in depth about what we're looking for from challenge participants. And I'm looking forward to providing an update to you, hopefully at a future meeting, about the submissions that have come in and what we're doing from there. So thanks so much. The next slide's just a summary of where you can send an email, what the deadline is. So if you're interested, definitely check out the website and start working on your submission. And I'm looking forward to connecting with you all again soon. And I think I have one more question from Vivian. Thanks for the question around the number of anticipated submissions. So my team at Mars, we run a lot of different innovation challenges. That's the role that we're playing in this competition. And I would say every competition has a different number of submissions. We've seen anywhere from 10 to 100. So it really depends on the challenge. This challenge has pretty significant requirements from a submission. We are asking people some questions. We're asking them to complete a summary of the types of data that they're able to collect, as well as a video demonstration of how their solution works. So it might lessen the number to the lower side, but I still think we've gotten a lot of interest. We've had 3 informational webinars, and each one's had about 50 or more people attend. So lots of interest. We'll see what it looks like in terms of submissions, but glad to see the questions, and I'm happy to engage with any of you over email or over in another call if you'd like more info.
Thanks so much, Louise. So now we're going to move into our first roundtable set of presentations. So there's 6 presentations, 5 minutes each. We are going to be doing question and answers in a different format. So that will be happening after the presenters have had a chance to share their information with you. And we will go over that process for question and answers after you've heard these 5 presentations. So to start us off, it's my pleasure to introduce Lovisa Cheung. She is a PhD student at the University of Toronto, and she's going to share with you a project that she and some of her peers completed last year in the final year of their physical therapy program at the University of Toronto. Lovisa, are you online?
Yep, I'm here.
Great. Pass it over to you.
Okay, so thanks, Kristen. Hi, everyone. As Kristen said, my name is Lovisa. I'm a Master's of Physical Therapy candidate and just started my PhD in rehab science a few weeks ago. So our project that we did was investigating the perspectives of people living with a spinal cord injury on activity-based therapy. So I'm honored to be spending a few minutes sharing a bit about this project and what my group and I have learned from it. So I'm just going to turn off my video for this presentation because I'm not sure how good the connection is in the hospital. So our objectives of our study were to explore the benefits and challenges of ABT, the facilitators and barriers to accessing ABT in the community, as well as the motivators for seeking out and participating in ABT programs. So now I'll just go over a quick overview of our methodology. So what kind of study did we conduct? We conducted a qualitative descriptive research study using semi-structured interviews. So our interview guide was developed using the Theoretical Domains Framework, or TDF. So if you don't know what the TDF is, it's a framework that allowed us to kind of probe multiple different domains, including knowledge, skills, identity, and beliefs, and so forth. Who did we recruit? We recruited 10 participants with spinal cord injury who had engaged in ABT. So these were adults with a chronic, complete, or incomplete spinal cord injury who participated in ABT within the past year in Canada for a minimum duration of 2 months. How did we analyze the data? We used the DEPICT model and conventional content analysis. The DEPICT model was suitable because it enabled collaboration within our large research team, which had varying levels of qualitative research experience. Next slide, please. So the data that we collected from our interviews are represented in a graphic as shown on the slide. Our central theme, which is located in the center of a diagram, highlights that ABT is a key part of participants' evolving and lifelong recovery process. And 5 categories emerge from this theme. They are number 1, participants' motivation to initiate ABT, and that's on the left side of the diagram. The subcategories include experience in early rehab, as well as initial expectations, goals, and motivation. Number 2 was participants' experiences of recovery. So that's at the top in green. Our subcategories included neurological recovery, health benefits, independence, and a sense of community. Number 3 was perceptions of how ABT contributes to recovery on the bottom right in blue. And it included the focus of ABT, the clinician mentality, and also mental effort. Our category number 4 was perceptions of factors limiting accessibility and participation in ABT. So the bottom left in pink there. The subcategories included cost, awareness and availability, and messages from healthcare professionals. And finally, number 5 is taking ABT to the next level, and that's on the right side of the diagram. This category involved advocating for ABT and some discussion on self-management and empowerment. So we extracted quotes from our interviews to illustrate our themes and categories and incorporated them within our manuscript. So for example, a quote from one of our participants kind of depicts our central theme. I definitely wouldn't be living in my own house, independent and improving, or on the road to walking again. Mentally, massive improvement. Physically, yeah, I wouldn't have known where to start. Next slide, please. So our study revealed that ABT is a form of physical activity and therefore may promote participation in an active lifestyle for individuals with SCI. Also, we learned that ABT is well positioned to provide realistic hope and peer support to help people adjust to life with spinal cord injury. Our future directions include organizing formalized peer-to-peer mentorship to address the lack of knowledge and awareness of ABT, examining clinician perspectives of ABT in order to guide the development of clinician-targeted ABT education and to identify challenges limiting that early implementation, and also exploring ABT's effect on cost of the healthcare system to better inform our funding decisions. So in conclusion, our study revealed that ABT plays a significant role in the ongoing and dynamic recovery experience in individuals living with SCI. ABT has an impact on numerous aspects of everyday life, leading to notable improvements across physical, functional, and psychological domains. However, there is a lack of knowledge and awareness of ABT, and that still remains a challenge. And that highlights our need to improve accessibility of ABT in Canada. So that's kind of all I'll be sharing on this neat project. Thank you so much for listening. And unfortunately, I may have to step out quite shortly. So if you have any questions about this project, Cindy and Kristen, sorry to put you on the spot, but if they were also involved in the study, so hopefully they can help answer any questions. Thanks.
Yeah, thank you so much, Lovisa. That was fantastic. And Cindy will cover the Q&A part for you later today, because I know you got to get back to the hospital.
Great, thanks.
Thanks, take care. Okay, next up, Dr. Chester Ho from the University of Alberta will share some work that he and his team have been doing. Chester, you're online, right?
Yes, thanks, Kristen.
Thank you.
Thank you. Good morning. I'm here to present this to all of you on behalf of our team. And I know that a couple of people from my lab are also here, so thank you. Next slide, please. So I'm not going to talk about what FES cycling is because obviously the group here is quite sophisticated. And so I want to talk to you about why we're doing this and also what we have learned so far and what the overall plans are. So we know that FES cycling in chronic SCI can reverse muscle atrophy, bone loss, and other chronic complications, right? Secondary complications after SCI. And we know that for FES cycling, most studies have focused on the chronic phase, and very few studies actually looked at the acute phase. And so our group was really curious to see if FES cycling can be feasibly started in the acute SCI phase. And we are thinking less than 3 weeks because animal models have shown that the critical window to start exercise would be 1 to 2 weeks post-injury. So considering what the practicalities are after a brand new injury, we thought that less than 3 weeks would be appropriate. And so we are wondering if it actually can prevent neuromuscular complications from happening as opposed to trying to reverse them in the chronic phase. And also, more importantly for us, we thought that it would be important to understand the neurorecovery using electrophysiology outcomes and also clinical and functional outcomes. Next slide, please. So the goal is to determine the effects of early FES-assisted cycling, starting within 3 weeks after spinal cord injury on neurorecovery and prevention of secondary complications. And so we have laid out a plan for the next few years. The first step was to understand the safety and feasibility of doing FES cycling in the acute care and trauma center setting, because we have to understand the context in our facilities in Canada, and also how we actually get this started in the early phase when our acute care team, at least in Alberta, are not as familiar with something like FES cycling. And so far we have completed this work, and I'll talk about the results in the next slide. And we have submitted our first manuscript for review and are preparing for the second one. And the next phase that we are just starting now is to gather some pilot data to plan for a future clinical trial that we are hoping to do. And we are very fortunate to be funded by Praxis for one of the ABT grants, and we'll be starting soon. And we also submitted to the Craig Nielsen Foundation for funding for also further pilot data. They do not overlap because the Praxis grant will be studying, FES cycling versus no cycling in 2 different acute care facilities, whereas the Craig Newson Foundation grant will be about studying, really early FES cycling versus slightly later, 3 months after people's injuries. And so still early, but not as early as just after 3 weeks. And then we're hoping that eventually we can do a clinical trial to determine efficacy. And so the question to this group really is, do we have an opportunity to have a Canadian multi-center trial for acute SCI study here?
Okay, moving along to Dr. Jose Zariffa, who is at the Toronto Rehab Institute and the University of Toronto.
All right, hi everyone. Thanks for being here today. It's great to have a chance to talk to this group. So just want to take a couple minutes to talk about some work that we've been doing, which is focused on tracking how people use their hands at home. And so I think that has a lot of intersections with what we're talking about today in terms of tracking fine motor type of activities in a variety of different contexts. So next slide, please. So the approach that we've been exploring is to use egocentric video, which is video from wearable cameras, to try to get some information about hand function outside of the clinical context, so at home primarily. And so the nice thing about these types of videos is that they give us really a ton of information. We can see what the hand is doing, we can see the postures that are being used, we can see the tasks that are being done, whether they were successful or not, what challenges somebody might have encountered. How often somebody was using their hand, or what, again, from an ABT perspective, what kinds of activities they might have been engaged in. We can get at things like number of repetitions. And so really rich kind of data. However, at the same time, because of the complexity, it's kind of difficult to analyze, right? It's difficult for anybody to sit there for hours on end and watch videos. So we need some methods to be able to automate the analysis of this type of data and to extract information that's meaningful to us in a convenient manner. And so from that perspective, we've been exploring a number of different machine learning techniques and computer vision techniques to try to automate the analysis of this type of data. Next slide, please. Okay, so I'll just give you a brief kind of overview of some of the types of problems that come up, or types of work that we've been doing. So on the top left there, one issue we've had to tackle was just finding hands in the videos, which sounds simple, but it's not when you consider that the hands, their shape is always changing. They're moving quickly. They're hidden behind objects. They're hidden behind each other. So teaching a computer, this is what a hand looks like, is not trivial. But thankfully, through there's a lot of been progress in a lot of deep learning methods for object detection, which can be adapted, and so we've kind of retrained some of those methods for finding hands, and that works quite well. So that's going well now. That was sort of one challenge that had to be overcome. At the bottom left of that slide there, you see another problem that we've worked on quite a bit, which we call the hand-object interaction detection, and that's simply trying to for every frame in the video, the classifier says yes or no, the hand is manipulating an object for a functional purpose. So it's really getting at quantity of hand use, essentially. And so that can get us at things like, again, number of repetitions, amount of time, amount of use of the hand, and duration of interactions, which might relate to some degree to difficulty. And so what you see in the bottom left there is the blue lines are the outputs of the algorithm, the computer outputs. So when it's high, the person was using their hand in the video, and the red lines are the manually annotated video, so human beings sitting down and kind of tracking, and so you can kind of see the computer capturing general trends of what's happening in the video. And so we initially did this kind of from a perspective of using it as a basis for some new outcome measures that could reflect performance of hand use in home environments. But I think, again, from the ABT perspective, there's a lot of potential for things like tracking repetitions and amount of exercise and this kind of stuff. And then more recently, if you look at the top right, methods have become available that allow us to track the posture of the hand, so track individual joints and fingers. And now that I'm quite excited about this, because now this opens the door to starting to look at the quality of hand use in addition to the quantity. And so that's really cool. And so we're more recently starting to explore some of these methods. So we just published one paper where we were able to demonstrate that we can detect when somebody is using a tenodesis grasp during a task. So again, from the perspective of detecting compensatory postures and getting at how people are using their hands, that's really interesting. We're also working on looking at sort of going through a video and grouping similar hand postures from the perspective of creating, distilling long videos into short reports that capture key points about how somebody is using their hand. So I think a lot of exciting potential there. So we don't have a lot of time today, so I'll stop there, but I listed a number of papers on this topic from our group. If you're interested in checking it out, I think these slides will be available afterwards. All right, so that's it. Thank you for listening.
Thanks so much for the update, Jose. I'll move us along. Next, Christine Poirier from the GF Strong Rehabilitation Hospital in Vancouver is going to share with us a KT project that she's been working on.
Thank you. So I'm going to share, I think last year I had a chance to briefly introduce what we were set out to do in terms of our KT project. And I'm happy to say that the neurorecovery project is completed now, so I have some results to share. So just to summarize briefly the project goals, were to explore physiotherapist perspectives, beliefs, and barriers using FES at our center at GF Strong. So and then also to look at supporting the physiotherapists and increasing the use of FES. So once we understand the barriers and the facilitators, we wanted to implement targeted solutions, hopefully with the goal to increase the use of FES in interventions to improve our patient outcomes. With sustainability in mind. So the next slide. So what we did. We first looked at the charts of, we just wanted to see what our practice was like in regards of FES. So we looked at the 10 charts of incomplete SCI clients, and we looked at how many FES treatments were offered, and we looked at, we found out several things that were missing, like, oh, the charting seemed to be a challenge, like we didn't know how many treatment sessions were offered weekly, and there were little things like that. We were like, oh, that's hard. We also collected the client information, demographics. So we collected all of that to kind of like get a good understanding first at baseline. Then we surveyed the physiotherapist. So there were 7 therapists, and so we started with the physiotherapy team here, the inpatient physio team. So we surveyed the therapist at baseline as well, and we had a focus group to understand the barriers and the facilitators further and have a discussion about what solutions the therapist thought would be possible. And we had a motivated group, of course. Our team, we're all keen to participate and look at ways we could increase the frequency of the use of FES in our treatment. And by FES, I mean by that, like it could be just the unit, like just on the putting it on quad and glutes and as people stand, or it could be just placing it on or the FES bike. We looked at all kinds of FES, but we were told keep it small, keep it focused. So we had to start somewhere. So we basically started with incompletes and mainly lower extremity. And so what we figured out the therapist needed, based on the barriers that were identified, they needed more training, more resources to refer to, and some clinical support too. What was very helpful for people who seemed to have, they wanted to have somebody they could just go to and ask questions and say, oh, I'm not sure, like, oh, it's not working, and can you help me troubleshoot this? So I was the champion for the year of the project. So I was just the person saying, oh, okay, yeah, I work on the team, so I could, I made myself available. As far as time goes, we wanted to organize all our units, place them on cart, on wheels, so that was easy for therapists to access the units. We color-coded the units. So the idea was to send a message that we wanted to integrate FES in what we do every day, so that it's not an extra thing that we have to do. And the training was a one-day training with Kristen Musselman. She came to Vancouver to train like 20 therapists, and that was followed by 3 practical in-services with our own units, so the therapists could play with the units and become familiar with them. The resources, we created a charting sheet. Like I said, charting had been a challenge, so we said, let's make a sheet, tick sheet. So it's and a patient selection tool as well to guide decisions regarding to selecting parameters with FES and which client should be getting FES. So just to support clinicians who may be new or less experienced with it. So I'll go to the next slide. And yes, so this is what we implemented. So like I said, we surveyed the therapists. So the results of the survey. So the first question was, how often do you use FES in your treatment? And to improve arm function, so on the left side. And the second one, improve walking function, improve muscle strength, endurance, reduce hypertonia, spasticity, and improve sensation. And you can see in blue was the data at baseline. So, and then in orange and was at 6 months post. So like about a month or 2 after the course and after the in-service, so 6 months post-implementation. And then in gray was at 12 months, so just to see if there was, if the change was maintained. And yeah, we're glad to see that it was maintained. And so all the therapists, this was self-reported, of course, but they all said, yes, I use FES more in my treatments. So the next slide. So we also looked at the level of confidence, again, self-reported by the therapist. So we used the visual analog scale in the survey. And again, at 0, 6, and 12 months, you can see the difference. So after the implementation in orange, it shows a big jump in confidence. So from about 43% in terms of client selection, when as high as 80%. So after the course and after the in-services, everybody felt like, yay, I think I can do this. I know who to offer FES to. And then the second question was selecting parameters. And again, big jump here also in terms of the clinician confidence. So our hypothesis was, if the clinician feel more confident with using FES, then they will probably use it more in their treatment. So let's see what happened when we looked at the charts. So next slide. So when we looked at the chart, we wanted to see, again, we started with the lower extremity. So the percentage of eligible clients who received any FES. So, and so that could have been just like a one-off and things like that, right? So, and then on the right was those who received more like a regular dose of FES. So we included people who receive FES at least like 1 to 3 times a week for 3 to 6 weeks. Length of stay sometimes is a little short, so we went for that. At baseline, 6 months and 12 months. And again, you can see a change after implementation that was maintained at 12 months. So that was also interesting to see that therapists were getting using more FES with their clients. And again, the next slide just shows the number of FES treatments just in terms of sheer numbers counting in the charts, and improved for in total lower extremity. And I also counted upper extremity eventually because we were using it more for upper near the end because we had more tetraplegics. So that was very interesting to see the changes and exciting. And next slide just shows the conclusion here that there was a practice change. What was very important was to remain flexible and really engage the participants, the physiotherapist, in finding the solutions, and also address the specific barriers that we had at our center that are a lot what happens elsewhere too. I don't think they were very different, but so you kind of have to tweak it a little bit for your team and the culture. So we were sensitive to that, to those things. I would like to acknowledge my co-team member Nafisa Amlani and Professor Janice Eng, who was our mentor, and Kristen Musselman, source of inspiration. And yes, we had a $5,000 grant to conduct this KT challenge. So thank you for listening.
Thank you, Christine. It's very exciting to see those final results. So fantastic, well done. 2 more talks to go, so before we have our break. So Dr. Kei Masani from the Toronto Rehab Institute and the University of Toronto will be speaking next.
Hi, thank you, Kristen. Hi, everyone. So I'm Kei Masani. I'm a scientist at the KITE and a professor at the U of T on the biomedical engineering side. So I'm from tech side. So today I want to showcase the 3 projects. I think the same as the last year. Under the umbrella of ABT related researches. Can you please go to the next one? Thank you. So the first topic that I will introduce is the FES therapy for standing. This project is under provision with Dr. Christine Masuno, and first supported by U of T, and now kindly Praxis Foundation kindly support us, as well as CIHL and SAC. So under the support, we first, better to explain the idea first. So the idea is that the person do the visual feedback balance training, and on top of that, we want to add FES. By doing that, we believe that that facilitates a training effect. And key is that the controller mimics how brain activate muscles. So, yeah. So this is a FES therapy for standing balance. In the first pilot study, we had 5 participants, and everybody showed improvement in the biomechanical measures, as well as semi-structured interviews. They gave us, all of them gave us a positive impression. So I think this project is promising. So in the next stage, we found several issues in the control and the system. With the support by Praxis, we want to improve the system to make a better system for the larger scale testing. And then at the end, we want to make this system fully wireless so that everyone can easily use this. Next slide, please. So the second topic that I want to introduce is this project related to fatigue reduction in FES. So the big issue in any FES exercise is rapid muscle fatigue. We have been proposing this thing under support by CIHR. So the left bottom slide graph may be better to show that. So the red, blue line is a regular FES. In this case, angle of generation. So it shows the rapid muscle fatigue. But using our method, which we call SDSS, we alternatively activate muscle fibers, we think. We can reduce muscle fatigue a lot. So in general, we found that we can achieve 30% of muscle fatigue reduction using this method. So in the next step, we have been developing some small adapter by which any FES device can use this method. So these adapters can be connected to any FES stimulator, any FES cycling, or any like muscle training, so that we can reduce muscle, can expect a muscle fatigue reduction in any exercises. Also, we did some theoretical study showing on the right top to investigate the mechanism of this method. So we found that by doing this method, the muscle fibers are alternatively activated as hypothesized and with lower activation frequency, about 20 hertz or so. And the right bottom, I show that the current study ongoing, which is on the FES rowing. So we wanted to use this method in FES rowing to show how much we can extend the therapy time in FES rowing. First, we found that the FES rowing is kind of difficult to do for beginners. So we at first developed the coaching app by which we can indicate when the person should trigger the FES stimulation. And then at the right bottom, I show that the example of data. So red line is regular FES rowing. It's showing power curve, time course. And so it's clearly shows that SCDS is kind of prolong the therapy period. So, okay, next slide, please. The last topic that I want to share is the FES therapy mechanism. So FES therapy has been shown that it's effective to promote neuroplasticity and improve movement, but the mechanism is not very clear. So we want to investigate the mechanism using some experiments. And particularly, we are now investigating what's happening under the electrode on the muscle. So in the majority of neurophysiology experiments, people use nerve stimulation, and which is a bit different from the electrode on muscle. So we have been working on that and showing that on the right top, we show that the motor point of stimulation, that is a electrode on muscle, is slightly different from the nerve stimulation. So right top figure, I show that that kind of stimulation does not induce the H reflex in soleus muscle, which is different from nerve stimulation. Also on the right bottom, so we believe that the effect of FES therapy, the essential mechanism of FES therapy is somewhat depending on the spinal neuroplasticity. So the spinal PAS is kind of essential mechanism of FES therapy. We have been showing that on the right bottom, even with motor point of stimulation, we can achieve spinal neuroplasticity by combining with TMS through the spinal path mechanism. So in the next step, we are comparing the spinal FES therapy as to the spinal PAS, and to show that the mechanism are kind of shared. Yeah, so that's what we have been doing. Thank you for listening.
Thanks, Kei, for that update. And last but not least, Dr. Sarah Donkers from the University of Saskatchewan will spend a few moments talking about some work that she and her colleagues have been pursuing.
Hello again. Some amazing projects. What a fun event to be a part of. So thanks for having me. I'm going to briefly introduce my recently funded project titled Building Towards a Neurorecovery Model of Care. And I don't have too much insight or any data to share yet, as we haven't started, but I do have a lot of excitement about the project. So we'll go with that. Basically, based on an improved understanding of our nervous system and the role that rehab can play in driving neuroplasticity, supporting rehab interventions that promote neurorecovery is needed. And we know that rehab interventions promoting this functional recovery include access and support for higher intensity and frequency of task-oriented practice, active client engagement in these activities that are continually being progressed to challenge someone's functional ability and their impairment levels. And we're really learning more about the importance of including a behavioral transfer package to reinforce the transfer of those skills to real-world environments. But how to implement all of these components into our current healthcare system remains a challenge, and models of delivering this healthcare that can provide rehab services to continue to support the recovery function need to be explored. So I should note here that in Saskatchewan, we have a really small population that's spread over a large area. So our entire province has 1 million people, and we only have 2 cities over 50,000. So there are some unique considerations for access to care, but also ways to continue to support that neuro-recovery process to our rural and remote populations. We also don't have any condition or injury-specific care. So we don't have a specialized spinal cord injury hospital or ward. We just have neuro, right? All of it together. And I think that has some strengths with regards to positively implementing change across conditions. Okay, so getting back to the project, historically, rehab has been structured to deliver compensatory approaches. And in most neurological conditions, the advances in our understanding of the nervous system, but also in those factors promoting neurorecovery, especially in the last 10 years, have led to this push to be able to address those factors and promote neurorecovery early on. And we're really at this point where clinical practice needs to change. So the methods of delivering these components in a manner that's appropriate to our current healthcare context is what we're going to explore. We're taking a participatory health research approach. So myself and key collaborators include individuals with neurological conditions, healthcare providers, our health authorities, so our provincial rehab director and our decision makers within the health authority, as well as managers from both our local neuro rehab and chronic disease management divisions are going to be part of this 3-year multi-step project. And the purpose is really to collaboratively inform and co-develop and then evaluate this comprehensive approach. And we envision that happening through 3 main phases. So engagement, co-design, and then those initial piloting steps. So we'll have an immediate evaluation, but then the longer term follow-up and modifications will be made ongoing. And the hope is that this approach will establish a network that's going to maximize the change in care and inform our future research, but also future funding priorities. And I think it'll be a very important step in strengthening these networks that are required to advance rehabilitation innovation here in Saskatchewan, and hopefully we can inform and share our lessons learned to other provinces. So combining the current and emerging evidence and elements of what we know from the literature that would support neurorecovery, but with this participatory approach, so we can find a intervention or an approach that is feasible, will be, I think, an important starting point to enable meaningful local change, but as well as sustainable quality improvement at that healthcare systems level. Thank you.
Thanks, Sarah. That sounds fantastic, and congrats on the funding for that project. So we're going to move on to roundtable 2. So we have another set of 6 presentations.
Hi, everyone. Thanks, Kristen. I really love this format. I think it's going to work well. And I'm a complex project that really is, we're really trying to put like a 10-year plan of developing a system that might help us identify what works best in activity-based therapies. And in fact, all therapies, I guess, physical therapy and likely occupational therapy. And so really we're taking a bit of an implementation focus, which is really developing some infrastructure, but trying to map those into the sort of the clinical processes that happen. And essentially we sort of start with this concept that's on the screen right now, where, you know, therapists or clinicians of all type really, you know, try to understand their patients and have all kinds of different forms of assessments and have understanding of the interventions that they've done in the past and are in the literature, and they try to, you know, try things and determine what works by doing hopefully standardized assessments and seeing outcomes. And then with that wisdom and expertise comes some treatment planning. And essentially it's an iterative cycle. And really what our approach is, and if you could just click the next, I guess, slide. I've got some animations in here. So really what we're hoping to develop is some infrastructure that, although it says data decision support, it's much broader than that. It's just some software and some other tools that will assist the clinicians in all these processes. And in the end, we hope to build in some artificial intelligence that will start, and you'll hopefully see with this presentation, how we aim to do that. And you can click the next slide. And I just wanted to note, although we have a fairly large group of people involved in sort of a community of practice approach and a very participatory approach, like Sarah was just describing, a very participatory approach that involves researchers, persons with lived experience, some data scientists, and then some clinicians, therapists on the ground. These are sort of the core people that are involved in the work that I'm presenting here. And you can go forward to the next slide. And so what our approach is really trying to understand or characterize the different components of the care process. Starting very simply, just thinking about, what assessments are done, what goals, how does goal setting happen, what's the treatment planning process, what therapies, how do we characterize therapies, and then what outcomes flow, but acknowledge again that iterative flow. And so you can click the next. And really the idea is, using largely the register, the Praxis registry, but maybe with some tweaks, really trying to implement in practice that's a standardized assessment approach where we use this standing walking assessment tool developed by Kristen and others, and really that then feeds into what assessments are done to help characterize the initiatives. The key thing is implementing that well in practice. And then if you click the next slide, the other part of this that we don't traditionally do well is really understanding what therapies are actually done. So we spend a lot of time looking first at literature and then just trying different iterations. Basically, and it is a constantly iterative approach to improve this, a system to try to characterize therapies with a neurorecovery / ABT focus. And then finally, if you click next again, the result of this really is about being able to, and again, this diagram, really the details aren't important, but the idea is that once you have these things, at least in digital and or objective format, you can start to look at patterns of what the therapeutic activities are relative to the outcomes. And as soon as you start to look at patterns, then you can click the next again. That's really where things like machine learning, reinforcement learning, different artificial intelligence approaches might help to look for relationships around the patterns of therapeutic activities on the ground and the outcomes. And so that's really where our work is going. And next slide. And so really we have done some, just over the past 6 months or so, we have done some preliminary work just exploring an AI approach. Dan Lazat and his student Nathan Phelps were really behind this. And it was Nathan's master's thesis work that really explored looking at the data that we had captured on 100 patients and really knowing from an AI perspective what the challenges are going to be. Essentially, you can see some of the challenges there. I think we all could say that, we have very messy, from especially a data science point of view, data about what we do in practice. And therapists on the ground have lots of choices for things. They have some knowledge about which choices they're going to make. But unlike many approaches, there are many interventions that are actually possible. And although the data can be obtained in advance from, again, an AI approach, the policy guiding those things is either unknown or there's different viewpoints on what guides a therapy decision. On the plus side, there are some therapies can be structured in a way that they can be grouped. Like for a given patient, you would probably only consider a certain set of therapies. And you can click next. And so what really Nathan and Dan did was develop a simulator just to explore some early concepts that really clustered treatments in different ways and tested some preliminary reinforcement learning strategies using the SWOT, or the Standing Walking Assessment improvement, as a primary outcome. And then various simulator parameters were estimated based on an actual patient data, messy or not. They used sort of two basic approaches, one based on domain knowledge, where their starting point was our taxonomy and the groups that were inherent in that taxonomy. And then they used a word embedding algorithm to create another approach for reinforcement learning that clustered treatments together based on that word, sort of a word finding approach. If you click the next, then the really lots of results came from this. And this is just a graph, one of the graphs that were output that really shows their, in essence, their domain knowledge. So based on our taxonomy, when you, in the parameters used in this simulator anyway, did outperform the other aspects of the simulator. So that was exciting for the therapists and for our own work, that at least we had created something that made some sense, at least to this early simulator work. But more importantly, the results, that if you click on the last sort of set of information, the real key for us was that we at least are started down a path that we want to continue on. We want to continue to explore reinforcement learning or other approaches, potentially Bayesian approaches in this artificial intelligence realm. But again, the most important is we realize we want to work together. Data scientists in particular have a lot to offer. And so we have some ideas about things that we're doing actually this fall in terms of collaborations between the data science group and the therapists and researchers on the ground. And lastly, we'll continue to develop really our practice-based research approach, which is continuing to get data in as systematic way as possible. And we're in the midst of developing some software to try to standardize the data that happens with the goal of really enlarging and potentially using these in larger and larger networks as we sort of have something that is useful to assist with implementation in practice. And I'll leave it there. Thanks for this opportunity.
Thanks, Dalton. Great update and great to see how the work is progressing. So we'll move on to next speaker, who's Anita Kaiser. She's a PhD student at the University of Toronto. Anita, I'll pass it over to you.
Thanks, Kristen. And thanks for having me here to share some brief overview on some of the work that Kristen and I have been working on in the past year. Kristen, you can go to the next slide. Thanks. So, I mean, we've all heard some of the talks from earlier today, so we know that there are a number of challenges when it comes to delivery and implementation of ABT into our rehab and community clinics. The high dosage is often difficult to achieve in practice, and the intensive nature of the program does require participants to be highly motivated. The therapists need to be trained with some of the specialized equipment and techniques that are offered through ABT, and the program tends to be quite costly with some of those specialized equipment, as well as the need for multiple therapists, sometimes working with one client at a time. And there's also a lack of consensus regarding the standard of practice, as well as tools for measuring participation and performance. And I know Kristen's already given an overview about the ABT Summit that was held back in 2019 and the 5 priorities that were identified through the summit. So we've actually chosen to focus our study on addressing one of those priorities, which is the development of a tool to track activity-based therapy after spinal cord injury. So our study is divided into 2 phases. And in phase 1, we actually look at developing the tool, and that's been graciously funded through CIHR. So in this phase, we start first with doing a systematic scoping review to identify the characteristics and types of ABT that individuals with spinal cord injury participate in across the continuum of care. And that would then be followed by a Delphi method that involves both qualitative and quantitative rounds. So in the qualitative round, we're actually holding focus groups with 6 different stakeholder groups to learn about their knowledge and experience with ABT, as well as the characteristics and the parameters that they think would be most useful for us to document and keep track of. And then we'll be actually synthesizing the data from both the scoping review and those focus groups in order to develop the quantitative Delphi survey, where we will administer to roughly about 100 stakeholders. And we'll look to using that survey to help us to narrow down and identify the content that we would include in an ABT tracking tool. So once we have that information, we'll actually develop the tool and then move into phase 2 of the research, where we'll look at doing some psychometric testing of the tool. And so that'll start first with doing some content validity testing. We'll use that information to further refine the tool and then follow that up with some inter-rater reliability testing to look at agreement between both therapists and clients. And I should say that that phase of the study has received funding through Praxis, so thank you for that. So in terms of progress and where we're at right now, we do have a paper that's been published in BMJ Open that outlines a protocol for our scoping review, so you're welcome to go in and have a look at that. For our scoping review to date, we've completed the search and screening and have retrieved 84 relevant articles. We've also completed data extraction, and now we are working on synthesizing that information. We've also started working on the qualitative Delphi round, and we've managed so far to date to complete 7 of our 11 focus groups with our selected stakeholder groups. So looking forward to finishing that and analyzing that information as well. And in terms of outcomes, we are looking at producing an ABT tracking tool that can be administered through both our rehab and community-based clinics across Canada. We anticipate producing about 7 to 8 papers through this work and look forward to sharing our findings widely across conferences, both nationally and internationally, as well as through webinars, through targeting our different stakeholder groups. And I think one of the key strengths of this project is the strong partnerships that we've been able to build through it, and that's reflected also in our research team. So if you go to the next slide, I just want to thank all the individuals and the centers that have been involved in this project, as well again to our funders, Praxis and CIHR, and also like to acknowledge Toronto Rehab, TD, and CIHR for supporting me with my studies. So thank you.
Thanks, Anita, for that great update. And next, we're moving on to Dr. Laurent Bouyer from Laval. And Laurent, I think you were going to, do you have slides you want to share?
Yeah, is that okay?
Yeah. I'm going to stop. I'll stop sharing. And
let's see if that works.
Perfect.
Can you see my screen now?
Yeah, looks good.
All right. So thank you for having me and giving me a chance to present one of the projects that we're doing here in the lab as an interdisciplinary team. Actually, the work that I present today is funded by Praxis through the ABT program, and I'm actually, speaking for all these people and many more. So this will be very short because we're early in the project. But basically, the question we had is with the development of new technologies such as robotics and FES and so on, how can we bring into the what we're am I muted? Can you hear me?
Yeah, we can. You were muted just for a second.
Okay, So yeah, so the goal of this project is to see if we can bring the clinic together into the project early on to make sure that if we develop a way of doing locomotor training with spinal cord injured participants, that the clinicians feel empowered and they have a say in the whole project. So there's basically two parts to this, but the overall aim is really, can we make sure that what we design in the lab will make sense in the clinic. And we decided to basically go with our foundation and buy an exoskeleton with them. So it's really a partnership from the beginning. And as we were looking for different models, we found one which had FES also available. And it's the same model, I think, Vivian, that you have from Indigo. So basically there is one commercial device that you can buy where you can do both robotic training and FES training at the same time. Our goal here was really to see if we could use exoskeletons as a way to enhance neuroplasticity. So basically as a training tool, not as a walking aid. And this is why we thought, working with the clinic would be the best way to do this. So how did we plan on doing this? Well, it's a 2-year pilot project, if you want, where we were going to build a logic model. So basically design with the clinicians what they think would be the best approach to bring in this technology into their regular practice. And then also do a small crossover study to look at the added benefit of FES on top of the locomotor training. And we can talk some more after those 5 minutes, but just to give you an idea, you can do FES as full contraction, or you could also use FES just as a way to make the nervous system in a more excitable state, so that the actual therapy from the robot can work better. So we're looking into all of this. Basically, the device we bought is an Indigo exoskeleton. The advantage of this model, I'm not gonna spend too much time on it, but it's adjustable. All the sections are adjustable, and it's not very big. And here you see one of my students walking in the device. It's not an actual person with a spinal cord injury, but this is a good demonstration of the device. And within the back plate, you have the 10-channel FES unit that you can use to stimulate the muscles at the same time. The good thing is you can use their program to apply the FES, or you can program it yourself and change the parameters. So basically we have a very large goal, which is to have an advisory board, have clinicians bring in from the get-go, and then get into a combined, basically scientifically viable approach to make sure that we can look at the efficiency of overground locomotor training in the clinic, but that this design is also compatible with clinical time and patient fatigue and so on. So this is the big model. I'm not going to spend too much time on it. Just want to show you quickly what a logic model is, because that's something I didn't know when I got into this project. This is why we're doing this as an interdisciplinary team. And basically, sorry for the French here, but I'll put you through it quickly. There are both aspects on resources, activities, what's expected from the clinic, what we really get, and how we can do iterative corrections to make sure that the program is really fit to the needs of both sides, of both the patients and the clinicians. And at the same time, we are using quantitative and qualitative analysis of the data. So for example, how many sessions you get per week, how many clinicians look at the videos we produce, and so on. And then also have group interviews and individual interviews to look at obstacles and facilitators. So it's really something that is undergoing right now. COVID was a real kill for us. We had to modify slightly the program. Because of that, I'll get into this in a minute, but it was really a good way of getting the clinicians and a researcher at our site to work together. In terms of the efficiency of adding FES on top of the actual locomotor training, basically what our goal is to have a crossover design where we would do roughly 12 training session, either with the FES or without in one group, and then have a mid-program assessment and then switch it over. So in terms of project timeline, what we've done so far is gone through ethics and so on. We've started two literature review, one on the FES parameters during walking with devices, and we basically found very little in the literature as we expected. So we were at about 13 or 14 papers that addressed this. With multiple muscle stimulation and exoskeletons, we're down to only about 4. So there's a lot of place for our work to be there. As I said before, because of COVID, we changed slightly the way we did this. Instead of having focus groups, we decided to have individual interviews over Zoom. This worked out actually quite well. So we had a couple of videos prepared showing the technology without too much information, but showing the technology to clinicians. And then one of our research PT interviewed them. We have 11 out of the 13 interviews done at this time. And we see a good buy-in from the clinical side. So the next step, now that we have adjusted our protocol to COVID, is to finalize those interviews, and then we're going to have the clinicians come and try the exoskeleton so that they feel what it's like. And then between now and Christmas, the next step will be to play with the FES parameters on healthy participants initially, and then on I don't know what the English word is, but patients, external patients or outpatients. And then eventually, when we're ready, we will be able to bring the device for inpatients on the other side of the rehab center, and then it will be used on inpatients. I hope I didn't overshoot too much in terms of time. I'll be happy to take questions. Thank you.
Thanks so much, Laurent. It's great to hear what your project's all about. I believe Vivian is up next, Dr. Vivian Mushahwar from the University of Alberta. And Vivian, did you want to share your screen?
Absolutely.
Okay.
Let's say share. Okay, let's maximize this. Are you guys able to see my screen now?
Yeah, we can see it.
Wonderful, and clearly you can hear me. So I really would like to start by thanking all the organizers for the summit. I'm really very excited to be taking part of it today. And the message that I want to impart in this talk is that engaging the arms simultaneously with the legs in a rhythmic, active, and load-bearing activity-based therapy can improve walking capacity after spinal cord injury more than engaging the legs only. Now, so why do we say that? You know, we've proposed that engaging the arms along with the legs in an ABT paradigm for improving walking allows for the engagement of the spinal networks all throughout the cord. And this engagement is what is needed for effective walking. Now, what is the evidence for this? Well, we all know that when we walk, the arms swing in coordination with the legs. And the swinging is not just the result of the arms being a passive mechanical appendage. Instead, arm swinging is neurally driven, and the neural drive to the arms is coordinated with the drive to the legs. Now, this knowledge has been around for many years, and a number of investigators have suggested that the arms can actually modulate the motor output of the legs. However, to this date, the arms have not really been systematically involved in activity-based therapy for improving walking. So what we wanted to investigate was really whether engaging the arms simultaneously with the legs does indeed lead to functional improvements in mobility and after chronic spinal cord injury, and particularly focusing on walking. So the questions that we asked were, does coordinated arm and leg activation improve walking capacity? And if it does, what are the underlying mechanisms? Could it be that this engagement improves the cervical lumbar propriospinal modulation within the cord? And could it be that it would also enhance the descending drive to the legs? Now, for today, I will only focus on the first question in the interest of time. Now, to apply the intervention, we decided to use simultaneous arm and leg cycling as an ABT that is efficient in terms of staff utilization. And this intervention leads to coordinated activation of the arms and the legs, and we use electrical stimulation applied to the legs to assist in the generation of the movement. In this pilot study, we recruited 15 adults who are experiencing chronic spinal cord injury with an AIS rating of C or D. And the level of injury was C4 to T10, except for one person who had a C3 incomplete injury. The participants were divided into two groups, one group that received arm and leg cycling simultaneously, and one group that received leg cycling only. Now, the training involved 1 hour a day, 5 days a week for 12 weeks, and electrical stimulation was applied to the same muscles between of the legs for the two groups. And the idea was to, again, to assist in completing the cycling task if they were too weak to produce cycling on their own, and to also provide a phasic sensory input to the spinal cord during cycling. Now, we did extensive assessments, and of course, all the assessments were performed without stimulation, and they were either clinical, biomechanical, or electrophysiological. But for the interest of time today, I'll only focus on a couple of clinical assessments that we performed. And that is, the first was our primary outcome measure, which is walking speed, the 10-meter walking test. And what you see on the x-axis is training time in weeks, and on the y-axis, change in walking speed as a % of each person's initial pre-training walking speed. And both groups started with a walking speed that was not significantly different from each other. What you can see is that both groups significantly improved their walking speed over time. However, the group that was in the arm and leg cycling improved their walking much more than the group in the legs only cycling group. Now, we see a similar picture for one of the secondary measures, and that is the improvements in walking distance. That's supposed to say walking distance, my apology. And that was a 6-minute walking test. And here we see that both groups improved, although the arm and leg cycling group improved more. But at this time, because of probably our small sample size, the difference was not significantly different from the leg cycling group only. But if we were to compare our results from the pilot study to current approaches for improving walking, which are gait-specific interventions, and here we looked at a large number of studies that with an average improvement in either walking speed or walking distance. And the numbers here you see are the numbers of participants in each study. And the black dashed line shows you the average improvement relative to across all these interventions. If we now, whoops, sorry, going the wrong way. If we now look at the results from our pilot study, you could see that the leg cycling group had similar improvements to that seen across all gait-specific interventions. However, the arm and leg cycling group had at least twice the improvements in walking metrics relative to gait-specific cycling. Gait-specific interventions. So if we were to just look at this video very quickly, this is a person who received the arm and leg training paradigm. We're looking at the person before training and after training. The harness is just used for safety only. It's not providing weight support, but you could see the difference in walking quite clearly. Pre-training, he's walking slowly, he's hunched over, he's looking at the legs because he can't actually feel his legs. Yet after training, he's walking that same distance twice as fast, he's upright, and really showing clear improvements in his walking capacity. So to wrap this up, I hope that this pilot study has been able to demonstrate two clear points. One is that cycling translates to improvements in walking. This is very important, but that active engagement of the arms in coordination with the legs leads to larger improvements in walking. We believe that the underlying mechanisms, and we've got proof to that, showing that improvements in cervical lumbar modulation and improvements in corticospinal drive may have led to these improvements. And we also found that all participants were highly receptive of the intervention and really wanted to continue. So just moving forward, and the significance of the work so far, we think that arm and leg cycling assisted with electrical stimulation is really readily translatable to the clinic. And it could be applicable to neurological conditions other than spinal cord injury. We're now utilizing transcutaneous spinal cord stimulation to the cervical cord as a means to further enhance the modulation of the lumbar region of the cord and improve walking even more. This is relatively new funding from CIHR. And we're also looking at how the arms on their own, arm cycling alone with transcutaneous spinal cord stimulation could improve walking to further really tease out that arm component and its effect on walking. And we're also interested in seeing if we are able to combine arm and leg cycling with transcutaneous spinal cord stimulation, perhaps we could enroll people with more severe spinal cord injuries. I'd like to end by thanking the outstanding group of people who have contributed to this work, and of course the funding agency without whom we won't have been able to do it. Thank you.
So our next presenters, we have Dr. Vanessa Noonan and also John Chernesky from the Praxis Spinal Cord Institute.
Great, thanks so much. Hi everybody, and thank you so much for coming to this ABT Expo. We're going to talk to you really quickly about spinal cord stimulation and some of the work that we've undertaken here in Canada through Praxis and also around the world. Just to get you guys all up to speed, we refer to spinal cord stimulation as either the electrical or magnetic stimulation of the spinal cord. This methodology is used to increase the excitability of the spinal cord and can induce volitional movement and functional control of motor circuitry as well as autonomic functions. The two methodologies that are used are either the invasive implanted epidural stimulation, where the electrode array is implanted onto the dura mater outside the spinal cord, or the less invasive transcutaneous method. You can see on the image to the right there's an individual with some electrodes set on the outside of his neck. And so this is another method that's been shown to be effective. Epidural stimulation or spinal cord stimulation has been approved in Canada for management of pain, but now some pioneering researchers are looking at how it can be used to improve functional recovery of individuals with spinal cord injury. So this is still in the research phases. It's not yet approved for clinical application, but the evidence is mounting that it seems to be effective. As I mentioned earlier, there's been shown to be improvements in both motor and autonomic functions. Not aware of any evidence to show improvement in sensory functions yet, but again, it's still in its nascent stages. So a long ways to go. There has been significant media coverage of this. One of the individuals that was injured in the Humboldt Broncos crash actually undertook some medical tourism and traveled overseas to explore this technology. As I say, currently it's in the research stages in different parts of the world. There's not yet any studies that have been launched in Canada, but there are multiple studies in the United States and in Europe and in different parts of the world. And in some less regulated countries, they're actually delivering it as clinical practice. So yet the evidence is still not there to show whether it's effective and whether it's truly safe. This is an area of focus for Praxis. We do focus on neurorecovery, and we feel that potentially spinal cord stimulation has the ability to be delivered in adjunct alongside ABT. There are some research that's being using them in concert, ABT along with stimulation, to try to improve this functional recovery. So that's why we've included it in this expo. It has been identified as a priority by our stakeholders. And we've already funded some work supporting some spinal cord stimulation.
So pre-screening, you're probably getting quite accustomed. I know here in Alberta, we all know the questions that you get asked anytime you go somewhere, but we take it very seriously. So when folks come and our staff do the pre-screening questions, going through that list in terms of COVID symptoms, having interactions with people, all of those things, we take it very seriously because we want to keep our participants safe. So for example, we had an individual coming in for his FES appointment. He was one of our first members who had come back, and he indicated that he had had a fever on the weekend. He said it was due to a bladder infection, but unfortunately we weren't able to let him come in and exercise. And so it's been really interesting trying to work with our members to communicate how we're trying to protect the health and safety and well-being of everyone, while still working with their ability to exercise and to maintain kind of their overall health and well-being. On to the next one, please. So when it comes to mask wearing, this one is essential. Many communities across the country require mask wearing in an indoor setting. For us, it's a little bit different because we have folks who are engaging in exercise. So staff are required to wear a mask while they're on shift and in the gym. And then we've made it optional for members. And this was to give them a little bit of personal choice in terms of their own comfort level and what is appropriate for them, knowing that they are going to be engaging in exercise. To the next point, so just covering up. So this is what a current kind of model or image would look like, because we do have staff who are masking up all the time. And it's kind of a funny picture because now our staff are also maintaining physical distancing as much as possible. So this is one of the pieces that we were able to really control with FES, because folks come in and they're set up on their bike and they're not moving around the gym space. So we have now our bikes are spread out. So we have 2 meters distance between the bikes. And we've encouraged our staff to work with members who are independent enough to be able to set themselves up for FES, to do it on their own. We've also been providing more direction for those who come with support staff to get the support staff to do the setup. And then if that's not possible, then our staff are stepping in and they're helping to set folks up. So lots of different things where we're trying to maintain physical distancing. Then we also have managing support. So moving on to the next one. So again, this is where we've been working closely with the support staff that come in with our members. So really just thinking about how can we provide tips and tricks so that the support individual who maintains a close relationship with that person all the time is able to do most of the hands-on support. Again, trying to limit the interactions with our staff while also trying to, create a positive, welcoming community kind of environment. So it's been interesting trying to maintain those positive relationships and have conversations and build all of those things that are important to people, but within this kind of new reality as we try to keep everyone safe. And then the last piece, which members are not doing, but our staff sure are, is the cleaning piece. And that's when you sign up for a job and there's other duties as assigned. Unfortunately, we've had to kind of take that on and get our staff to be more involved in cleaning. So constantly cleaning high touch surfaces. And, we have our cohort working out in the gym from 9 until 12. We then close for an hour so staff can do a deep clean. And then we bring in the next round of folks beginning at 1 o'clock. So having those strategic schedules to allow staff time and opportunity to be continuing cleaning and keeping our space safe. So those are just a few things. I wanted to sort of share our experience about what it's been like. Our FES members have jumped at the opportunity to come back. We have all of our program time slots are full. We are definitely at capacity, and we are continuing now to work with some of the other community locations in Edmonton who are open so that we can make sure that people have access to the FES Cycling training that they need. We know that that's not a program that is easy for people to do remotely. We've been doing some remote one-on-one training, but having an FES cycle, having an FES bike in your home is not financially feasible for most people. So being able to come to the Sedgwick Center is absolutely critical. So just kind of wanted to share some of that, give you an idea of what it's like in the community as we're trying to make sure that people continue to have that long-term access. And one of our goals over the next year is to really document the impact that returning to FES cycling has had for members, because we know that it's really important for them in maintaining their quality of life, or at least we know it anecdotally. So I think there's definitely a need for more research when it comes to the long-term maintenance piece around the impact of things like FES cycling on quality of life. Next slide. That's it kind of for me for today. If you have questions or you'd like more information about what's going on at the Sedgwick Center, my email is on back on the first slide, and I'd love to hear from everyone. So thank you very much.
Thanks so much, Jen, for that update.
So I just wanted to thank all the speakers for sharing your work. It's really exciting to see all the things happening in the area of activity-based therapy. Thank you all for attending. Special thank you to Kristen Musselman for hosting the event, and for Sophie Ebiseri for all her work in organizing and supporting the expo. And the activity-based therapy community practice will continue to share ongoing activity-based therapy related activities with the group. So hopefully this is the beginning of more to come.